Pre-transfusion testing. So transfusion safety and red blood cell survival. So transfused red blood cells should survive adequately in the recipient's circulation without causing significant destruction of the patient's own red blood cells. For pre-transfusion testing, there is strict adherence to all parameters of pre-transfusion testing, which is essential to ensure safe blood transfusion therapy and prevent any adverse reactions. These are the steps for pre-transfusion testing. For testing standards, so the most common cause of transfusion-related deaths is actually clerical errors, such as incorrect ABO blood grouping or patient identification. The consequences, so these errors can lead to the transfusion of ABO incompatible blood, which can cause severe and potentially fatal hemolytic transfusion reactions. For prevention, we have strict verification processes, and double-checking patient and blood unit details are critical to prevent such errors. So the primary cause error, like mentioned earlier, the most frequent error in transfusion is the misidentification of the recipient. So to prevent such errors, strict and exact procedures must be implemented and followed for identifying the patient, which is the recipient, labeling and handling the recipient's blood type, and matching and verifying the blood donor unit. The staff responsibility, so all personnel involved in transfusion therapy must adhere to these protocols to ensure patient safety and prevent transfusion-related complications. We have to use 2 unique identifiers, and this helps to ensure accurate patient identification and prevent transfusion errors. So at least 2 unique patient identifiers must be used. Common examples include first and last name with the date of birth and/or medical record number. There's also automated identification technologies. So to further reduce human error, automated identification methods are increasingly employed. And this can include barcodes, so scanning patient wristbands and the blood units for quick and accurate matching. And also radio frequency identification, or RFID, so the use of radio waves to identify patients and samples without direct line of sight, enhancing safety and efficiency. For the collection of patient samples, so both serum and plasma samples can be used for pre-transfusion testing. Proper labeling procedures, so these tubes must be labeled at the patient's bedside immediately after collection to prevent misidentification. This includes using imprinted labels with patient details, ensuring the label matches the patient's identifiers, making sure their name, their date of birth, their medical record number all match. So you do this at the patient bedside. And then we also do a verification in the blood bank. So upon receipt in the blood bank, all sample information must be cross-checked against the requisition form or the order in the computer to confirm patient identity and test order accuracy before proceeding with testing. For compatibility testing, we'll look at the recipient's ABO group, so determining the recipient's ABO blood group to ensure ABO compatibility with the donor blood. We're also going to look at their RH type, so identifying the recipient's RH factor, if it's positive or negative, to avoid any RH incompatibility. We're also going to do an antibody screen, so screening the recipient's plasma for any unexpected or clinically significant antibodies that could react with donor red blood cells. Then, before the unit is brought up to the patient, we're going to perform a cross-match. And performing a cross-match test is mixing the donor red blood cells with the recipient's plasma to confirm compatibility and ensure no adverse reaction will occur. We're also going to review records. So record keeping for patient testing is extremely important. So a comprehensive record must be maintained for all results obtained during the testing of patient samples. This includes the patient's ABO group, RH type, and any unexpected antibody screenings performed. Any unusual serologic reactions encountered during testing should be documented, and the identity of any unexpected antibodies detected in the patient's serum must also be recorded clearly. So the first choice for transfusion is blood and components that match the patient's own ABO and RH type. When ABO group-specific blood is unavailable or insufficient supply, alternative compatible blood groups must be selected. This ensures timely transfusion while minimizing the risk of incompatible reactions. So the use of RH negative blood, this can be safely given to RH positive recipients, but it should be primarily reserved for RH negative patients, especially females of childbearing age, to prevent sensitization. The use of RH or of antigen negative donor units. So this is required when unexpected antibodies are detected in the recipient's serum to avoid hemolytic reactions. We're also going to do a visual inspection of donor units. So before transfusion, these donor units should be visually inspected for any signs of hemolysis or clots, which may indicate compromised blood quality. For cross-match testing, so the cross-match test traditionally involves mixing the patient's serum with donor red blood cells to check for compatibility. This includes an immediate spin phase, which is a quick test to confirm ABO compatibility. And then we do an antiglobulin phase, which is a more sensitive test that can detect antibodies that may react at body temperature. So there are really two types of cross-match. So we have immediate spin and antiglobulin. If you're in my class, this is a video on how to do some cross-match testing. There was also a video on the previous slide, so make sure you watch both of those. So the cross-match test serves as a final check of ABO compatibility between the donor and the patient. It can detect antibodies in the patient's serum that may react with antigens on the donor's red blood cells, even if those antibodies were not identified during the antibody screen. This can happen if the corresponding antigen was absent on the screening cells. Tube and gel card results must be interpreted according to the blood bank standard operating procedures. In compliance with the Code of Federal Regulations, all results must be recorded immediately in a permanent ledger using a logical system that allows easy retrieval. So both the actual observations and their interpretations must be documented. The primary objective of the cross-match test is to detect antibodies in the recipient's serum, including anti-A and anti-B, which could destroy transfused red blood cells. The cause of any incompatibility must be determined, and the review of results of the autocontrol and antibody screening test must also occur. So causes of incompatible cross-match could be that there is an incorrect ABO grouping of the patient or the donor. Could be that there is an alloantibody in the patient's serum reacting with the corresponding antigen on the donor red blood cells, or an autoantibody in the patient's serum is reacting with the corresponding antigen on the donor red blood cells. Some other causes of incompatible cross-match, there could be a newly developed alloantibody. The alloantibody to a low incidence antigen that was, usually not found on an antibody panel. They could have a warm reactive autoantibody or even a donor positive DAT. So a computer cross-match. The computer cross-match compares recent ABO serologic results and the interpretations on file for both the donor and the recipient being matched. Compatibility is determined based solely on this comparison, and there is no physical cross-matching test with donor red cells and recipient serum is performed if the computer cross-match is used. This method requires accurate and up-to-date serologic data for both parties, and it is typically used when there are no unexpected antibodies detected in the recipient's serum. For emergency release, so sometimes the recipient requires transfusion of red blood cell components before pre-transfusion testing is completed. Transfusion must proceed according to an established protocol. You need to ensure that adequate pre-transfusion samples are collected for testing. The patient's ABO and RH groups should be determined as soon as possible, and maintain accurate and thorough records of all transfusion activities during this time. The patient's physician must authorize the release of the red blood cell units, which basically just means we didn't, have time. They need it now. We didn't have time to do the testing, so the physician has to sign off on it, knowing there are potential risks. And like mentioned earlier, the cross-match testing may not be complete at time of the emergency release. So that's where that, authorization comes in extremely handy. And we need to just make sure that we have it documented on our side in the lab. For post-transfusion testing, so if donor units of an ABO group are different from the recipient's own blood type, have been transfused, special testing could be required. So before administering any additional red blood cell transfusions, a fresh serum sample from the recipient must be tested. The test checks for the presence of unexpected anti-A and or anti-B antibodies in the recipient's serum. So compatibility testing procedures are not required for transfusion of plasma products like they are for red cells. So for transfusion of large volumes of plasma and plasma products, a cross-match test between the donor plasma and patient red blood cells may be performed. However, current standards do not require that there is a cross-match test for any plasma products. For massive transfusions, these are defined as administration of 8 to 10 red blood cell units to an adult patient in less than 24 hours, or acute administration of 4 to 5 red blood cell units in 1 hour. We would use antigen negative units for patients with known antibodies if possible, and the physician must sign a waiver of testing or a release form for all untested units given during transfusion. For neonatal transfusions, so blood for an exchange or regular transfusion in neonates, this is anybody younger than 4 months old, should be compatible with any maternal antibodies present in the infant circulation and reactive at 37 degrees Celsius or anti-human globulin phases. The ABO and RH testing is required, and so is antibody detection testing as well. Blood should be as fresh as possible and not older than 7 days. For intrauterine transfusions, so blood for intrauterine transfusion must be compatible with maternal antibodies capable of crossing the placenta. So we need to consider fetal ABO and RH status. So if fetal ABO and RH are known, we're going to use group-specific blood. If it is not known, we're going to give our O-negative blood products. We're going to always check for maternal antibodies and donor antigens, and we're going to ensure no fetal maternal ABO or RH incompatibility. Cross-match testing is performed using the mother's serum sample. So there are some limitations on compatibility testing procedures. So there is no current testing procedure that can guarantee the fate of a transfused blood unit. Even if a cross-match is compatible, it does not guarantee that the transfused red blood cells will survive normally in the recipient. For issuance of blood components, so the same careful approach used to properly identify the patient before the sample collection must be applied to ensure that the recipient is indeed the same person who provided the initial blood sample for testing. Accurate patient identification is critical to avoid transfusion errors. For verification of donor unit and bedside check, so the actual blood product and its accompanying test records must be verified to ensure they correspond to the same donor unit number. The bedside check, performed immediately prior to blood administration, is the most critical step in preventing mistransfusion. Proper verification helps avoid transfusion errors and ensures patient safety. For documentation and labeling of the blood, so a statement of compatibility must be retained in the patient's permanent medical record if the blood is transfused. A label or tie tag must be attached to the blood unit indicating the identity of the intended recipient, the results of pre-transfusion testing, and the donor unit number. So for issuing, there is some technology related things that we have that can help for patient safety. One of them is a machine readable ID, especially barcode systems. These are ideal for bedside checks. These systems have been shown to significantly improve transfusion safety. We have radio frequency identification that can be used to enhance identification accuracy and improve tracking and safety at all stages of the pre-transfusion testing phases. So information must be verified at least twice before transfusing any blood product. So before blood is taken from the blood bank to the patient treatment area, we have to verify the ABO and RH test results, presence of any clinically significant unexpected antibodies, and history of adverse reactions to transfusions. And then before transfusion begins, a reliable professional, usually two, must verify patient identity, donor product identity as well. They'll use a system of positive patient identification, which includes comparing the wristband identification with the compatibility forms. And this protocol must be followed strictly to prevent errors and prevent, from killing somebody.